Nick Majerison here. Welcome to Top Med Talk. Now, before we get cracking, Top Med Talk is going to be at the International Fluid Academy Day on November the 23rd in Amsterdam. Full details, topmedtalk.com. Click on the section marked Events. You'll be able to find out more. It's on November the 23rd. It's in Amsterdam. It's the International Fluid Academy Day. Going to tell you more about that towards the end of the podcast. In the meantime, it's time for today's Top Med Talk. And today's Top Med Talk is a continuation of Smoking Kills More Than All Addictive Substances Combined, plus Car Accidents. That's the title of this podcast. This is part 2. It's presented by James Davis, Director of the Duke Smoking Cessation Programme, and it tells you how you can stand up a preoperative smoking cessation programme at the institution where you work. It's taken from the hugely successful EBPOM-USA Master's Course, a Perioperative Care Practicum, which took place in Atlanta earlier this year. Have a listen, and I'll give you some words at the end.
Top Med Talk. So there have now been recommendations, consensus on how to approach this. We haven't done it in the U.S., but they did a nice job, I think, in France with a set of recommendations. These are guidelines on smoking management, and they kind of came forward to say, looking at all of the studies, current smoking increases 30-day mortality by 20% and postoperative complications by 40%. That's consistent with the data that I was just showing you. It includes increases in wound infection, pneumonia, intubation, pulmonary embolism, ventilation in the first over 48 hours, stroke, coma, cardiac arrest, myocardial infarction, transfusion, sepsis, septic shock. This is a very impressive list. Current smoking increases all complications except for ENT surgery, and there's just not enough data on ENT, though I think there may be a study out now in 2018 on this. And the overall evidence is high. Their recommendations, we recommend offering behavioral management and prescription of nicotine replacement before scheduled surgical intervention. I think we can actually do better than that, and we'll talk about how. We recommend cessation as long as possible before the surgery. Thumbs up on that. I think that's exactly right, and we recommend that all professionals involved, the positive effects of involved inform smokers of the positive effects of quitting. Their emphasis, though, was really to get smokers to quit regardless of how soon it was after surgery. And I think there's probably some nuance there that we need to dig into and sort out. And we will have ways of kind of managing that ourselves clinically and kind of making our best judgment. But I'd like to see better data on that first month and what's really helpful and what's not. So let's talk a little bit now about what we do for smokers. How do we manage this group effectively? So here are the self-directed quit attempts. It's 3 to 5%. Those are the numbers for our current population. If they just say, you know what, I'm going to quit and give it my best shot. Unfortunately, going to CVS or Walgreens and picking up nicotine gum or nicotine lozenge does not change that. It's very interesting, but when a provider is not involved, I don't know what's happening. If they're not getting pharmacy, the pharmacist is not helping them to dose these things or is not explaining it. But the over-the-counter patches are not changing those rates either. But it's been a little unfortunate to see that really hasn't moved the dial much. Provider and advice and treatment. This is when a patient comes to their provider says, I think you should quit smoking. Let's kind of go through some of the steps of this. These tend to be, 2 to 5 minutes of discussion, realistically. And then people are most commonly put on nicotine replacement, maybe some other medications. On average, the abstinence rates for that are 10 to 12%. These abstinence rates and all the abstinence rates that I'm describing are biochemically confirmed 6-month point prevalence abstinence rates. And that means that we're looking at these smokers 6 months after they've quit to say, are you really quit? The reason that we wait 6 months is that sometimes smokers quit for a month and then they go back. And at 6 months, we start to get a sense of what really long-term smoking cessation rates are. So, and I say biochemically confirmed, meaning that when I have a carbon monoxide monitor, I give that to a smoker and they blow into it, then they get very honest about what's going on with their smoking. They just don't feel like telling me a story if I'm going to catch them. The quit line does just about as well as this. I work with the North Carolina quit line pretty closely, and they've been coming up with all kinds of innovations, but they have not been able to move the dial past that 11%. Again, this is biochemically confirmed abstinence. When we look at self-reported abstinence, the rates are much higher. When you get into specialized treatment, we're going to talk about this. I'm going to talk about the Duke program, but the Mayo Clinic has a similar program. UNC has a similar program. But these are essentially team-based programs. They all have very similar elements. Then you get much higher abstinence rates. And this is this is very exciting. But 40 to 50% is essentially 10 times what people are getting when they go to CVS and they pick up some lozenges. So it's really we're really moving the dial here, and it's very exciting to see it. Quit rates in the perioperative setting are a little different. When we ask people to quit before surgery, and then we assess their ability to quit before the surgery occurs. Again, it's a much shorter period of time, and they have this immediate motivation. This is, we're kind of saying over and over again that this is an educational moment where people are actually able to learn. But with brief advice, we're not at 10%. We're at 25%. And again, shorter term. We're not going out to 6 months. Shorter term, but this is also biochemically confirmed. When you bring in an intervention, then you can essentially double that. Then you're up at 46%. These interventions, this is 22 studies, almost 3,000 smokers. I would say this information is relatively good. There's great heterogeneity in the interventions that were looked at across these studies, but most of them were run by nurses, and most of them use nicotine replacement. Again, I think we can move the dial significantly from that. I think that we can do a lot better than 46% prior to surgery. So what does improve outcomes? The first thing is evaluation, then evidence-based medications, evidence-based behavioral treatment, and follow-up. This is a lot bigger than advice and a brochure. And let's talk about each one of these. So the first is an evaluation. As I said, kind of starting out, smokers are not they're not the general population. This is a highly comorbid population, and the comorbidity that smokers have is often very closely tied to our approach to them. The first group is high dependence. About 15% of smokers have very high-level nicotine dependence. In a history, what I'll find is they smoke within the first 5 minutes of waking up, they have terrible withdrawal symptoms, and they've often been on medications and essentially said it didn't do anything. The medications, I tried nicotine, but I had the same withdrawal symptoms, when we look at a constellation of it's 10,000 genes, then we actually see that this is genetically determined. There's a large, and this is George Uhl that did this work in 2008. It's a neat study, and it's a shame because we can't do a test in the clinic to look at 10,000 genes. Maybe in a few years we can, but we have not been able to. But we can suss out these people pretty quickly. This group responds very well to specific pharmacotherapy regimens. But if you don't get your meds right, these guys don't quit. And that's kind of the story. When they have really severe withdrawal symptoms, behavioral treatment isn't going to move the dial. It requires real pharmacotherapy, and we're actually seeing varenicline combinations doing very well with them. So we'll talk about that in a minute. High stress and poor coping skills. This is someone for whom you can put these people on meds, and they're not going to respond because they're smoking to manage stress. So withdrawal symptoms aren't the issue for them. So I want to paint a picture that not every smoker is smoking for the same reason. And when we try to get them to quit, not every smoker is going to respond to the same kind of therapy. So high stress, poor coping skills. Anxiety, depression, PTSD, bipolar, major psychiatric illness. Again, this is 30% of all smokers, so it's not an insignificant portion of our population. And for many of these people, they're actually smoking to help manage their illness. What happens when a person has anxiety? So a smoker, nicotine lasts in the blood about 2 hours. When nicotine levels go down, they start to go into withdrawal symptoms. Dopamine levels drop, norepinephrine levels drop. That causes their anxiety symptoms to get worse. And then they smoke, and their anxiety symptoms improve. The experience that they have is, I'm smoking to control my anxiety. In fact, they're smoking to control their withdrawal, but withdrawal is exacerbating their anxiety. And so with these folks, we need to get their anxiety under control to help them get over their smoking. Schizophrenics are a very interesting population because they have attention control problems, and PTSD looks kind of the same way, where in a schizophrenic and somewhat in PTSD, the mind will jump from one thing to another. It's very difficult for them to maintain. Well, smoking increases norepinephrine levels, and that increases their ability to maintain concentration. So, in fact, nicotine is medicating their illness. And if they stop using nicotine, that norepinephrine goes away, and they end up having worse symptoms of schizophrenia. So we need to have treatments that, again, just to say it, these folks need to be managed with relationship to their psychiatric illness. Alcohol and drug use. So 70% of alcohol dependents, people who are alcohol dependent, smoke. 30% of smokers drink. Drinking alcohol is highly correlated with relapse. So if you have a smoker who drinks alcohol, 30% of them do, and they don't stop drinking, there's an 85% chance that when they're drinking, they're going to go back to smoking. It just means that we can't ignore it. And again, I think the paradigm has been to say smoking is kind of its own entity. It's in a black box. Let's give it this and make it go away. And what I'm saying is that in reality, it's become a more complicated situation because we now have a more highly comorbid population. Low self-efficacy. There are behavioral tools. Motivational interviewing is the big one that is helpful for that. Weight gain. So we all know that, or most of us know in the smoking world, that when a smoker quits, they put on 5 to 10 pounds. That's something that's just kind of broadly kind of known. We all say, look, the benefits of smoking are going to outweigh the weight gain that you put on. I think that's true if they put on 5 to 10 pounds. The truth is that about 15%, about 1 out of 7, puts on 30 pounds. So this, like everything else, there's a continuum of weight change that occurs among different individuals. People who put on 30 pounds of weight commonly go back to smoking to lose the weight. So we have 15% of our population who can't quit or won't quit because they really are going to put on a lot of weight. And unless we address weight issues, they're not going to quit smoking. So again, different categories. Social support, health literacy, that's my crew. There's the health literacy group, and economic challenges also. And I think that those are, we all know the struggles that we kind of face with those. So how about medications? The first, I listed 4 items: evaluation, medications, behavioral treatment, and follow-up. With medications, kind of the standard way of treating most people at this point is to put them on a nicotine patch, use nicotine gum or lozenge. What we get in terms of abstinence rates is an increased abstinence of about 0.7, 0.6, 0.7, 0.8%. If you assume this abstinence rate table on the end assumes that they have a 10% abstinence rate simply by showing up at the office, and you here have a highly functional person who would have a 10% abstinence rate, but it's just to allow for a comparison. There are 2 kind of treatments that are really outliers now, that are really not in the pack, and that's varenicline and then combination NRT. And we're now really thinking of these treatments as standard of care. When I see a patient who's been put on nicotine patch alone or nicotine inhaler alone, or bupropion alone, bupropion is Zyban or Wellbutrin, I consider that to be insufficient therapy unless there's some clinical reason that therapy is being individualized to that person, which of course happens. Most of the time, I'd want to see a person on varenicline or patch plus gum or lozenge or inhaler. I list, inhaler up here. Inhaler is outrageously expensive and usually requires prior authorization to have an insurance company pay for it. Nasal spray is fine, but it's actually very effective, but 93% of people don't tolerate it, so it's because nicotine is slightly irritating. And then nortriptyl and clonidine are considered second-line treatments. In the clinic, we're using these kinds of treatments pretty commonly, and this is not, Duke out on the edge. I'd love to say that we're leading the pack, but the truth is, if you go to Mayo or UNC or Dartmouth, there are other Tufts, there are other programs that are using these kind of treatments as well. Nicotine matching. So a pack of cigarettes leads to kind of mean nicotine levels, about 18 nanograms of serum nicotine throughout the day. A 21 milligram patch leads to 12 nanograms of nicotine throughout the day. So a nicotine patch, a 21 milligram nicotine patch, is what we normally think of as reasonable replacement for a one-pack-a-day smoker. In fact, it gives about 2/3 of the nicotine. So we're often under-treating our patients in terms of the amount of nicotine that they should be getting. If you match nicotine, if you really kind of figure out how much nicotine a person needs to get to cover the nicotine they've been getting from smoking and get them up to those levels, we see abstinence rates jump. Again, we were looking at abstinence rates of 17% with patch. Now we're up at 23%. So that's a nice jump. When we use varenicline and bupropion together, we really get a big jump. Varenicline and nicotine patch together, we really get a big jump. Again, these are not large meta-analyses. These are trials, but they're well-run, big randomized controlled trials, and they're more than one trial kind of showing the same thing. Adaptive treatment is also very common, and that's where we start a medication and we see how people respond to it, and then we change the medication dose and change the medication regimen or dose based on their response. What I typically do in a clinic is I'll start somebody, say I'm starting somebody on varenicline. I start them on varenicline. They come back in and they say, well, my urges didn't go away, so I add a medication. I see if they respond to varenicline, and then I'll add something where I'm starting them on patch and gum together, and then they come back and they say, oh, my withdrawal symptoms haven't actually gone away, so we increase the dose of the patch. Or they're saying that they have some side effects, so we decrease doses and we change that way. But that's an adaptive approach, and we do it with everything under the sun. I do it with my hypertensive patients for hypertension or for CHF. For some reason, we're just not in the habit of doing it for tobacco, but it works, and it works quite well. It just takes, in the perioperative setting, you need to see people in a very short time period because you're often kind of under the gun to get them quit before surgery. So there's some limitations there.
Top Med Talk.
Now, I mentioned that was taken from the hugely successful EBPOM-USA Masters course, a Perioperative Care Practicum, which took place in Atlanta earlier this year. I mentioned at the beginning of the podcast we're going to be covering the International Fluid Academy Day on November the 23rd in Amsterdam. Now, this is a great opportunity for you to meet the team if you want to come along. All you need to do is check out the website, topmedtalk.com, click through to events, and you'll find a full piece on the website detailing everything you need to know about the International Fluid Academy Day, November the 23rd. Now, we've set up a Slido account for people who want to interact with us and our guests during the International Fluid Academy Day. Here's how you get to that. Go to slido.com. I've got a login for you. It's hashtag TMTIFAD18. So IFAD, International Fluid Day 18, and TMT, of course, standing for Top Med Talk. So that password, once again, slido.com, hashtag TMTIFAD18. So TMT IFAD 18 is an easy way of remembering that. That's live from the Monday on the 19th. You can get onto there, put your question in early and have a chance of having it answered sooner rather than later. Don't forget that login, TMT IFAD 18. That's hashtag TMT IFAD 18, and that's on slido.com. And then, of course, if you think you can come along to the day itself, that'd be great. We'd love to see you. Amsterdam, November the 23rd. Go to the website, topmedtalk.com, and click on the section marked Events. Also, of course, you can download our full back catalogue at the moment here on Top Med Talk. All you need to do is go to your podcatcher and click Download All, or scroll through them individually and clicking Download on each one, or go to the website topmedtalk.com and explore our back catalogue, downloading as many as you can. It's entirely free. You can get all of the back catalogue at the moment. We're currently sorting through it, so it may not always be available in that form. So get yourself to the website topmedtalk.com and download all of our podcasts, our entire archive, whole back catalogue, many hundreds of valuable podcasts with incredible information within.